Hey, good evening, everyone. Welcome to another session of Virtual Global Spine Conference. It's my pleasure to welcome Dr. Rafael de la Garza Ramos today from Brown University. He's going to be speaking about frailty in patients with spinal metastases and the implications for oncologic spine surgery. Rafael is currently a oncologic and complex spine fellow at Brown University, which is the same place that I did mine under Diego Coslin and Toki Oilesi several years ago. And he'll be faculty at Albert Einstein University, and I was just informed in 10 days. So welcome, Rafael. Looking
Yeah,
forward to hearing your talk tonight.
thank you. Thank you so much. Thank you, Michael and Dr. Baj and Amna, for the kind invitation. Very, very happy to be here. And, I'll be talking today about a topic that's, personally, an area of enormous interest. I think, it's a topic that's rapidly evolving. It's very dynamic in the cancer population in general, as well as the geriatric population. And, I've been involved in research on frailty, I'd say probably about almost 10 years now. So it's really an area that's I'm passionate about, and hopefully we take a little bit of an in-depth dive into what frailty is and what it means for our patients, and how what we can do about it, which is I think the million-dollar question in a lot of research is, well, what can you do about it? So as you mentioned, the title of the talk is frailty in patients with spinal metastases, and these are really implications for oncologic surgery. I have no disclosures. So here's a problem. Cancer is very common. In the year 2019, there were approximately 17 million persons living with cancer. Every year, approximately 1.7 million new cases are diagnosed, and over 500,000 people die from this disease. If you look at this graph, which is actually, a graph from an epidemiologic study here in the United States, this number is only expected to increase. By the year 2040, we'll be looking at almost 25 million persons living with cancer. But most importantly, if we look at the color of the graphs, it's really happening in patients that are over 65 years of age. And this really brings, a sense of we're treating elderly patients with cancer. And they're bringing in, a lot of comorbidities. They're bringing a lot of things with them, over the years. And this is why it's very challenging sometimes to treat these patients. If we look at patients, with metastatic bone disease, we know it's the third most common site after the lung and liver. Every year, approximately 400,000 new cases are diagnosed, at least in the United States. And this is a table from a very famous paper by Coleman, published in 2006, that really shows that the incidence of bone metastases can be as high as 70% on postmortem examination, including obviously spine metastases, right? And we know these cause limb dysfunction, they can cause pathologic fractures, they can cause spinal cord compression, severe pain, and disability. When specifically talking about metastatic spine disease, we also see that it's very common, right? This is a study that was published only a couple of years ago. And it's a study, that shows that in patients with solid tumors, the incidence of metastasis is about 16% uh, every year. And if we look at the incidence of metastatic cord compression, this is about 10%. And the incidence of pathologic fractures is about 12%. And not surprisingly, we have the three most common cancers here, which are, prostate, lung, and breast, which take the majority of the burden of the disease. Specifically looking at cord compression, this is typically a late event, and survival time is pretty short. Median survival, what was reported in this study from 2016, was about 8 months. A 30-day mortality rate of 10% and a 1-year mortality rate of 62%. So it's a big problem. Historically, how we used to treat patients with cord compression, we used to do posterior decompression in the 70s and 80s. This was followed by radiotherapy in the 70s and 80s as well. And the reason, things change is because a long time ago, we used to always only do laminectomies, a posterior approach. And then this trial came in the 1980s, which basically compared laminectomy plus radiation, and there was really no difference in outcomes, right? No difference in pain relief, no difference in ambulation, no differences in sphincter control. So people were like, well, why should I put patients through a surgical procedure if just doing radiation is going to achieve the same outcome? So for a number of years, the paradigm changed, right? Where instead of just, putting patients through surgery, we were just doing radiation. And everything changed, and everybody knows this trial, but it's interesting that this only changed about 20 years ago. And this was a very famous randomized trial, multi-center, 100 patients, and specifically, the primary endpoint was the ability to walk. This was a trial that was ended early, given the significant findings. This included, patients with neurologic symptoms, including pain, and patients that were not totally paraplegic for over 48 hours, and compared surgery plus radiation versus radiation alone. All patients received steroids. But the key difference, if we look at the previous trial, the Young trial in the 80s, was that this trial, the Patchell trial, looked at direct decompressive surgery, which was a big change from what was happening before. And if we think about it, right, this is a picture, an MRI of a patient with high-grade spinal cord compression. And we see how the spinal cord is getting compressed circumferentially, right? So if we think about it, only doing a posterior approach, a posterior laminectomy, not surprisingly, was not enough, right? It would not be enough in this particular case. And what changed with the Patchell trial is that we were now doing direct decompressive surgery. So if a patient had circumferential compression, we would address, probably both pedicles, go in front of the cord as well. If the patient only had posterior compression, then yes, maybe just a laminectomy would be enough. If the patient just had unilateral, then maybe just a unilateral transpedicular decompression. But this really changed how we treated patients with spinal metastases. And not surprisingly, the outcomes were very favorable. This is just, a quick slide about, how the treatment groups, pretty comparable, in terms of age, tumor distribution, patients that were able to walk at the beginning of the study, location, etc. If we look at, the results, which were really why the trial was stopped so early, is that 84% of patients in the surgery group were able to walk after treatment compared to only 57 in the radiation-only group. Patients who underwent surgery plus radiation were still able to walk after 4 months versus 2 weeks, compared to patients in the radiotherapy group alone. So this is the primary endpoint, right? It was highly significant. In terms of secondary endpoints, this also favored surgery plus radiation. If we look at the maintenance of continence, being able to control bowel or bladder function, the radiation group was only able to do it for 17 days compared to 156 for surgery. Maintenance of the ASIA score as well as the Frankel score was, 72 days, which is about 2 months, compared to 500 days, which is over a year. Survival time was also there was also a benefit, perhaps not as, dramatic as the other outcomes, which is only 26 days, but nonetheless, it was also significant. So when do we do surgery for metastatic disease, right? So we typically say, that surgery for metastatic tumor patients is palliative, right? We treat patients who have neurologic compromise. We treat patients that are mechanically unstable. We treat tumors that are radioresistant because, radiation therapy has advanced, significantly over the past few years. So we typically try to do it on tumors that will not respond to radiation. We typically do it on patients that are supposed to live, around 3 months. And I put, a couple of asterisks because this has changed a little bit recently. There is some evidence showing that even patients that live less than 3 months may still achieve significant improvements in quality of life. So that's, still an area of ongoing research. And we try to figure out patients that are healthy enough, to tolerate surgery. And one of the main reasons for this is because the morbidity of oncologic surgery is very high, right? This was a paper from 2017 that I quote quite a bit, but it's a paper that did, a very comprehensive review on complications and found, the total complication rate to be approximately 27% with a range of 5 all the way to 76%, right? Multiple complications happen in 20% of patients, and about 7% up to 13% of patients, unfortunately, will not survive more than 30 days. So it makes it very challenging to try to figure out who will really benefit from surgery. We obviously don't want to put a patient through a major procedure if the patient's not really going to benefit from it, especially when the life expectancy is so short. So currently, I will say, most places probably in the United States, as well as worldwide, use a framework, right? There's a framework to try to figure out who needs surgery or who may just benefit from radiation, right? This is a framework that a lot of people probably are familiar with already, the NOMS framework, which looks at the neurologic, oncologic, mechanical, and systemic parts, of a patient, patients that have, low-grade cord compression without myelopathy, and it's a radiosensitive tumor, they can go directly to radiation, right? Patients that have high-grade compression with a radioresistant tumor or a previously radiated tumor might go directly, to surgery, separation surgery, followed by radiation. But what I really want to focus, the talk today is on the last component of the framework, which is the systemic part of it. And really the question that it's asking, right, if you look at it, is the patient able to tolerate surgery? And it's not only about can the patient tolerate surgery, will the patient be able to recover from the procedure to continue the systemic treatment? And it's not something that we may think about all the time, right? I mean, we sometimes ask our medical friends, what's the risk of surgery, right? And they might say, well, this is a risk of complications and this is a risk of mortality. But do we really know, right? I mean, is the patient going to go to rehab? Is the patient going to go directly to hospice? Is the patient going to be able to actually make it in time for his or her post-operative appointment with radiation oncology or with, to get systemic therapy? And there's many ways, we could try to figure out how to predict this, right? So we look at the patient's age, we look at the performance status, we look at the comorbidities, we look at, what type of tumor it is. We know that certain tumors have worse prognosis than others. Has the patient responded to chemo radiation? I mean, is this the first, second, or third line of therapy? What's the nutritional status of the patient, the muscle mass? What's the frailty of the patient? So now, we'll start talking about this idea or this concept of frailty, specifically in the context of cancer. It's a fascinating topic, and we could spend hours talking about it. And it was really, first described in the geriatric population. But in cancer patients, it plays a very, important and sometimes unique role. If we, want to try to define frailty, there's two ways, right? One is a simple definition, and some of you might be familiar with this. And for those who are not, it's basically a state of increased or extreme vulnerability to stressor that leads to adverse health outcomes. So it's a patient that, for some reason, if you put him through a stress, that being, a treatment, chemotherapy, radiation, or surgery, that patient is at a significantly higher risk of adverse outcomes compared to a patient that's not frail. If we want to look at the more real life definition, it's really a complex, multidimensional, and cyclical state of diminished reserve that results in a decreased resiliency and adaptive capacity and increased vulnerability to stressors. And it can be a result of increase in age. It can be a result of comorbid conditions. It could be a result of socioeconomic factors, environmental factors, psychological factors, and others. This is a nice figure that, I'll walk you through it, but really goes to show what frailty is. If you look at the far left, we have a patient that's fit or a patient that's non-frail. And this patient, has 3 springs here, which represent, his adaptive capacity. And if we add stressors here represented by this, red balls, the springs, shorten in size a little bit. If we add this same, 4 stressors to a pre-frail patient who now only has 2 springs, because his reserve is diminished, the same stressors push him further down. And if you go to the far right, and a patient that's frail who only has one spring, the same force stressors pushes him or her all the way down. Which is why, not surprisingly, right, if we see a patient who's, maybe 70 or 80 years old, who has COPD, who has renal failure, who also is malnourished, and, he gets a urinary tract infection, the same infection, compared to a patient that's otherwise healthy, a 40-year-old female, they behave completely different, right? Because the 80-year-old or the 60-year-old who has a bunch of comorbidities already on top of his age and perhaps other factors is not able to adapt, as well as the healthy patient. Its incidence, it varies. It depends also a lot on the tool that is being used to assess it, but in general, it's quoted that approximately 10 to 20% of patients over the age of 65 have frailty. And this doubles by the time we're 85, up to 20 to 40% of patients. In cancer, we know that elderly patients make a large portion of patients with cancer and cancer deaths. And it is estimated that over 50% of cancer patients will have frailty. And this is just a list of all the adverse outcomes that have been associated with frailty, right? Patients are at increased risk of falls, of cognitive decline, of hospitalization, institutionalization. And specifically for cancer, right, they don't tolerate chemotherapy as well, right? They don't tolerate radiation, and they tend to die sooner, right? They are more prone to disease recurrence or progression. This is a graph that shows, how, as I'm sure you're thinking also, right? I mean, frailty overlaps a little bit with disability or with chronic disease, right? But when you add cancer on top of this, it really pushes you towards the frail condition. And they're certainly at an increased risk of having disability and frailty. So how do we define it, right? So there's three key components. One is that multiple factors define frailty, right? Medical factors, environmental, educational, psychological, socioeconomic factors define frailty. Some factors, while associated, do not always define it. So it's sometimes difficult, I mean, this slide can be a little bit counterintuitive, but age by itself or a comorbidity by itself or being disabled because, patient who's, for example, in a wheelchair because he had an accident, but otherwise is healthy, that does not define frailty by itself. So it's important to keep in the back of our minds that it's really a multi-dimensional condition, and it's not, there's no one single factor that defines it. And it exists on a spectrum, right? I mean, we as humans, we'd like, to categorize patients, frail or not frail, which makes it, easier, for research purposes, right? But the reality, though, is that it's a spectrum, right? Patients, begin, with weight loss, with exhaustion, with weakness. This then leads to falls, complications, cognitive decline, all the way to failure to thrive and death. In terms of pathophysiology, it's complex. I mean, this is a graph, that takes us back to medical school. But if you look at the far left, we start with aging, with genetics, with environmental exposure, with disease, right? This triggers, oxidative stress, DNA damage, inflammation takes a big component. We have increase in inflammatory markers such as CRP or IL-6. And then this leads to anorexia, loss of bone mass, loss of muscle mass, decrease in cognition, prothrombotic state, all the way to the far right, which is the clinical syndrome of frailty, which is slowness and weakness and weight loss, fatigue. These are just some of the hormone and markers that are altered, in a patient that's frail. And we can see, the effect, right? And lower strength, increased inflammation, loss of muscle mass, which is very common in patients with cancer and frailty, loss of bone density, and, in general, worsening of performance, decreased gait speed, decreased appetite, and others. So there's two conceptual frameworks that are typically used to define frailty. The first one is the frailty phenotype. And it typically talks about having unintentional weight loss, exhaustion, muscle weakness, slowness while walking, or low levels of activity. And if you have three or more, you're considered to be frail. I think probably most of us, at least myself, I'm much more familiar with the frailty index, which is what we see a lot, in the literature, in the spine literature, in the degenerative literature, deformity and tumor literature. And it's basically an accumulation of health deficits. And this could be comorbidities, right? This could be physical comorbidities, mental comorbidities. It could also be social situations, right? A patient that doesn't have access, to transportation and can't make it to his or her appointments, or, can't have access to screening. This is going to result in a much more advanced disease than a patient who otherwise has access to that. So, it's really, again, multidimensional. What has been found, though, is that advanced frailty can be found by either. And more discordant exists when we're trying to define, is a patient moderately or mildly frail. There's, many different instruments to measure frailty. I mean, it's recommended that patients over 70 years of age and those with recent weight loss be screened for frailty. But there's currently over 65 or 70, different tools. Again, some based on phenotype, some based on index. And the reality is, unfortunately, as with a lot of things in medicine, there's really no consensus on what the best tool is. Some people use one single tool, which is, gait speed, for example. If you ask a patient to walk 5 meters, if they do in less, if it takes them longer than 5 seconds, you can, but the patient is a potential risk of frailty. The timed up and go score, which is the time it takes for a patient to rise up from a chair, walk 10 feet, turn around and come back, more than 10 seconds is also associated with frailty. Now, obviously, I mean, this should be used with caution, right? Because as we know, there's many different causes. There could be many different causes for this, right? And we shouldn't really be used one single metric to define frailty. This is, a survey that has been used in cancer patients. It's a self-administered survey. It's basically a collection, of items, and you add up the points. It looks at patients' age, how they rate their health, how disabled they feel, and what they can do, in terms of activities such as managing money, walking across the room. And if you have 3 or more points, you're, basically a frail patient. The Frail scale is also, a scoring system. You ask patients, are you too tired to exercise? Can you climb 1 flight of stairs without assistance? Can you walk 1 block without assistance? 5 or more illnesses, and this is the list of illnesses. Recent weight loss. And again, it gives you a point-based system and not frail, pre-frail, or frail. The phenotypic frailty, which is what we spoke about, a couple slides ago, is again, basically looking at the 5 criteria, which is weight loss, exhaustion, weakness, slowness, and low levels of activity. And more than three or more than 3 equals frail. This is another tool, study of osteoporotic fractures, frailty tool, weight loss, chair stance, and energy level. And now what we're more familiar with is the frailty indices, right? And these were popularized also about 20 years ago. And these are multifactorial and dynamic. And it's basically a collection of many variables, and the higher the frailty, the more variables you have, the higher the risk of complications, the higher the risk of length of stay, the higher the risk of mortality. This original paper, asked, if anybody was going to create a frailty index to include variables that were associated with health status. Deficits that increase with age, deficits that don't saturate too early, having a comorbidity or something that a lot of people are going to have. Deficits must cover a range of body system. And then, it advised, researchers to use the same variables to follow patients throughout the years. And it really said, you should add 30 or 40 variables to this frailty index. And obviously, what ended up happening is that you had this huge frailty indices, but they were extremely difficult to implement because you had a list of 30 or 40 variables and, it were very, very time consuming. and not a lot of people wanted to use them. And then what's also important is that this paper said that when sufficiently large number of variables are considered, the variables can be selected in random and the same results are going to be found. Which is very interesting because it talks about the importance of just having that accumulation. And at the end of the day, it didn't matter which deficits made up that particular, index. But if you had enough of them, the outcomes were going to be the same, regardless of which ones you chose. And this is the graph that illustrates that. This is a survival curve of men and women that started at the age of 70, and they were followed for 5, 10, 15, 20, 25, and 30 years, up to like 100 years. And you see, the survival probability as years go by. And the dark line, and then it goes to gray and then almost white, the dark line represents the group of patients that had the highest number of comorbidities or the highest number of deficits. And every line, which, I mean, you can see there's some, it's a bunch of lines clumped together. Every line represented a random selection of variables. And it goes to show how basically it was all about accumulating deficits. It didn't really matter which ones were accumulated, but if you had enough of them, it really pushed you to the worst survival curve. The modified frailty index 11 is something that I'm sure a lot of you are familiar with. It basically looks at 11 comorbidities and functional status, and you just add them up. And then it gives you, a result. And if it's, over 3.6, you basically count the positives and divide it by 11. It indicates frailty. The modified frailty index 5, which is a shorter version of it, which I'm sure a lot of you are familiar with. It just looks at 5 different items, which is diabetes, heart failure, hypertension, COPD, or pneumonia, or being dependent before surgery. And the higher the number, the higher the risk of frailty. The cancer-specific geriatric assessment is really a multidimensional and multidisciplinary process. This one focuses on multiple domains. And this is specific for cancer, but it's pretty complicated, right? We look at functional status, we look at comorbidities, cognition, mental health, and it's a series of questionnaires, a series of assessments. We also looked at the nutritional status of patients, the body mass index, history of a loss of muscle mass. And it's really, what ideally we should be doing in the real world, but it's complicated, right? It's not very easy. It's time consuming, but there are tools out there. Other measures of frailty, we sometimes don't think about, we might have been used to just thinking, it's just a collection of comorbidities, but social vulnerability is very important, right? At least here in the United States, this is a metric that was developed by the Centers for Disease Control. And it refers to the potential negative effects on communities caused by external stresses on human health. This was an index developed, to figure out how much at risk was a population by natural or human-caused disasters. And it's 15 different variables that are used to define this condition. It ranges from 0 to 1, 1 being the highest risk or the most vulnerable. And it looks at socioeconomic status of that particular neighborhood, household composition and disability, if elderly patients live in that neighborhood, if you have patients or people living with a disability, if it's a single parent household, if it's a minority family, for example, if there's crowding, if this particular person or house doesn't have access to a vehicle. And it's very interesting because this is a map. It's hard to see, but this is a map of Manhattan, New York City. And if we look at this particular neighborhood, which is roughly like in the Upper East Side, the vulnerability index for this particular block, piece of land, which is sometimes is multiple blocks, but it's a definite area. The index is 0.24, which is, pretty good. If we go up further north here on the right, on the Bronx, this particular neighborhood, the vulnerability index is 0.98, almost 1. And it really shows you how variable and how different a community and a patient living in the same city can be, right? And we don't typically think about this when we are doing, our assessment of how much risk does this patient have. Because again, if we're going to put the patients through a major procedure, but they're not going to be able to make it to their appointments after surgery, right? Or they don't understand, what's being told to them because of, language barrier or because, other factors. This is a patient that's much more higher risk and, more frail than a patient that otherwise has no issues. Mental frailty, is something that, a topic that is becoming more and more important, in research and healthcare. There's an anxiety short form, the PROMIS anxiety short form, and asking patients, whether they're feeling overwhelmed, whether they're feeling nervous, whether they're feeling anxious. This catastrophizing index, patients that, are going to have a very hard time coping with their disease and, going through a surgical procedure, for example. And these are things that, probably we're not even looking at. And again, going back to this idea of the cumulative, deficit, framework, we really need to look at everything. It's not just comorbidities. And I think, this is one of the key take-home messages that I want to, really emphasize today, that I think we need to look at frailty as a multi-dimensional condition, right? Function, energy, nutrition, disease, yes, obviously comorbidities, right? Vulnerability, mental health, cognition, etc. And to make things even more complicated, right, in cancer patients, there's a lot of overlap. There's a lot of overlap with frailty, with sarcopenia, with malnutrition or cachexia, with decreased strength, decreased performance, with fatigue, exhaustion. But this goes to show, how complex this topic can get. But at the same time, how exciting it is, right? Because there's a lot of opportunity for research and there's a lot of opportunity, to try to improve our patient outcomes. What about patients with metastatic spine disease? Well, I think, this is really, kind of like the focus of the talk, because I think, patients with metastatic disease, are a unique population of patients with cancer, right? These are very vulnerable patients, right? The disease itself makes them vulnerable, right? They are older patients. Patients come in with sometimes terrible back pain, pathologic fractures. They come in with limited mobility. They come in sometimes with neurologic deficits. They come in again with some socioeconomic vulnerabilities. If you think about it, a lot of the patients that show up in the emergency room with cord compression perhaps didn't have access to timely screening, right? They didn't have access to timely follow-ups, and they're presenting, at the far end of the disease process. And these patients are patients that are sometimes depressed, right? These are patients that sometimes, have a very difficult time coping with the disease or knowing that they're going to be paralyzed, for whatever time they have left, or that they're at risk of losing function. So, this was a project that I was very fortunate to be involved with. This was almost 10 years ago, actually, in 2016. I was doing a research fellowship at Hopkins, and we thought about, is there a way to measure frailty in spine tumor patients that's kind of unique to this population? And before this, there really wasn't much out there. So we decided, to use a large database, to come up with a large number of patients, to have access with a large list of comorbidities, and social factors, operative factors, and see if there's a way, can we come up with some sort of list of items that could predict morbidity, mortality, and length of stay after surgery. We looked at 4,500 patients with metastatic disease who underwent surgery. We only included patients with breast, prostate, lung, thyroid, and kidney cancer. We looked at over 25 different variables, and we did, univariate, multivariate analysis and factors associated with with inpatient mortality, inpatient major complications, and length of stay. This is a list of complications, 20% list of 20% risk of major complications, I'm sorry. The most common were, not surprisingly, respiratory complications, including ARDS, pneumonia, unplanned reintubation, renal failure, sepsis, PE, all the way down to myocardial infarction, shock, arrest, or stroke. And then we came up with, with this 9 different variables that were all found to be statistically significant with the outcomes that we were studying, right? And it included variables that, we were already familiar with, from the other indices, right? Like anemia, chronic lung disease, coagulopathy, electrolyte abnormalities, pulmonary circulation disorders, things like pulmonary hypertension or pulmonary embolism, renal failure, malnutrition, right? And then the bottom 2, I think, are probably the most important ones because these are things that maybe you may say, well, that's not really a comorbidity, right? But taking a patient emergently or urgently to the operating room, right? It talks about a patient that's much more vulnerable than a patient that comes in electively, right? A patient that comes in with back pain and, no neurologically intact. And even if they have a little bit of cord compression, it's very different from the patient that comes in with 24 to 48 hours of deficit, right? And same as the last one, which is basically patients undergoing an anterior combined approach, which talks about, much more invasive disease process or much more extensive, like a multi-level tumor. Our frailty index was, associated with outcomes, right? On figure A, we look at the mortality rate. Patients without frailty, had about a 2% risk all the way to 5 for moderately and severe frailty. Complication rate, it was a very nice stepwise increase in complications from 7% patients without frailty all the way to 34 for patients with severe frailty. Length of stay also increased, right? Almost doubled from the patient that did not have frailty all the way to patients that had severe frailty from 6 to 12 days. When we did, an area under the curve to see how the model performed, it varied by tumor type, which was not entirely surprising. Probably the best performance was for prostate cancer, followed by breast and thyroid. But it goes to show also how challenging it can be trying to predict outcome using a single tool. This is a review of frailty indices, in the metastatic spine tumor patients, which was published very recently, and very nicely summarizes what has been done, in the last few years. This paper came out in 2023, and it shows, this 4 different indices, all of which have been studying in the context of metastatic spine tumor patients. Not surprisingly, we have the modified frailty index 11, the modified frailty index 5, the metastatic spinal tumor frailty index, and then something called the hospital frailty risk score, which is a collection of ICD-10 codes, 109 different codes, and basically, it adds them up, And this group of researchers then publish, the different studies that have been made in the context of the frailty index 11, 5, and we go to show that, they all seem to be good at what they're supposed to do, right? The MFI-11 and both the MFI-5, sorry, they're both associated with outcomes, right? This metastatic spinal tumor frailty index was also associated with outcomes, in the original investigation, in another investigation using the NetScript database, in another investigation using a single hospital database, predicted length of stay, complications, non-routine discharge. There was another study that it did not find, it did not find it to be useful. The HFRS was also found to be useful, using different databases. And it goes to show again, how it may not really matter which tool you're using, right? At the end of the day, it's important to measure it. When looking at the prevalence in metastatic spine tumor patients, we see how common it is, right? In the original, metastatic frailty index paper, we found that 83% of patients were frail. You know, there was a study by Hirsch in 2021, I'm sorry, 80% as well. And a couple of studies from 2022, 57% and 77% of patients were found to be frail. So what about, how did the oncologic community feels about frailty? This is a very important and interesting paper that was published last year. And it was a study by the AO Spine. And it basically surveyed, the AO Spine group, asking, surgeons or providers that take care of patients with spinal diseases, what they knew or what they thought about frailty in the context of metastatic disease. They had, 360 respondents. 64 of them, assessed frailty by getting a general perception based on the condition and history of the patient. Kind of going back to what we saw in terms of the phenotype, right? Patient that comes into the office or we see in the emergency room that has decreased mobility, that perhaps doesn't have a lot of strength, that we don't think the patient is going to be able to get up and walk. Most of respondents, that's what they used. And, 40% used the comorbidity index, like the Charlson comorbidity index, which is just a collection of comorbidities. 27% used the frailty index. So a lot of people don't really use it. However, the community agreed that severe comorbidities and extensive oncologic disease and poor performance status were associated with frailty. So, if you ask them, if there's a patient with pulmonary disease, with renal failure, is that associated with frailty? And most people would agree with that, right? Specifically, malnutrition, liver failure, renal failure, and cardiopulmonary disease. And then, the community felt that the most relevant outcomes associated with frailty would be major complications, neurologic recovery, and change in performance status. So most agreed that it was important, right? But they used just like a general feeling, like a gut feeling of what frailty is, right? And it goes, again, further research and consensus is needed. But we know it's out there, right? We know people are thinking about it, but perhaps they don't know yet how to use it or what to do about it. So how do we approach the patient that's frail and has metastatic disease, right? I think the first thing and the most important thing is that it has to be a multidisciplinary approach, right? It has to be, done by spine surgeons, medical oncologists, radiation oncologists, medicine team, plastic surgery, palliative care, right? And the most important thing is that we need to look at the big picture. This is a case of a patient, a young man, unfortunate case, but this is a young man with lung adenocarcinoma, TP53, STK11 positive mutations, both, unfortunately associated with poor prognosis, PDL1 negative, who came in, with a couple of days of progressive lower extremity numbness, difficulty ambulating, not really paralyzed, but a couple of days of, markedly decreased in function. He had a little bit of back pain, not really mechanical. He's 4 out of 5 on the right lower extremity, severe numbness, intact bowel bladder function, unfortunately, with metastasis to the pelvis and liver. So really, kind of like an advanced stage, we know that this patient is not a candidate for immunotherapy or targeted therapies, with, progressive loss of function. If we go back to our framework, right, and again, looking at the big picture, so how would we approach this patient, right? So this is a patient, Franco D, right, 4 out of 5 in the right lower extremity, difficulty ambulating for about 48 hours. Oncologically, this is lung cancer. We know inherently it's, poor prognosis. Unfortunately, it has mutations that are not amenable to targeted therapy and that are also associated with even worse prognosis. He already has, visceral metastases to the bone. Lung cancer, we know it's radio resistant. And the prognosis given was about 6 months. Another oncologist actually said, probably even less than that. Mechanical, patient doesn't really have mechanical back pain. The SINS was intermediate, but systemic, right? Systemic is what we really need to focus on, right? His performance status was 2 based on the ECOG. The modified Bowers score was 3, which basically advocated supportive care. His BMI was 16. His hemoglobin was 10. If we look at the prognostic nutritional index, the PNI, which is a function of the albumin and lymphocytes, is low. Less than 40 is associated with malnutrition. His spinal tumor frailty index was 3. This is a patient that's malnourished. The patient has anemia. This is probably like an urgent, emergent case, maybe not something to be done in the middle of the night, but a young man losing function, maybe do it, first thing in the morning if it's late, and if not, as soon as possible. And this is looking again at the big picture, right? This particular framework is something that we used to do at Einstein, and we really encouraged all of the residents to go through all of these steps, and particularly in the systemic component, right? What's the functional status of the patient, right? What's the modified Bowers score? The Bowers score is a tool used to prognosticate survival, right? You could substitute it with something else, right? What's the BMI of the patient? What's the hemoglobin? What's the nutritional status? If you want to use a PNI or you want to use another tool, what's the frailty of the patient? Maybe you want to use an MTSFI, right? Or maybe you want to use something else. But you need to look at the whole picture. The most important thing is that frailty does not equal no surgery, right? There are options for the frail patient. Less invasive options exist, right? Especially nowadays, if you want to decompress, you can do a tubular approach for separation. You can do a mini open approach where you leave the fascia intact. You decrease blood loss, you decrease, muscle retraction, dissection. If you just want to stabilize, pathologic fracture in a neurologically intact patient, you can do percutaneous stabilization. You could use robotics, you could use navigation. You could also do a mini open approach, or you could do vertebral augmentation. If you want to realign the patient, a patient with severe kyphosis, you could also do a minimal invasive procedure, right? You could do a percutaneous stabilization or a mini open approach. So there are options for the frail patient. This is a study that, we published earlier in my residency describing, this tubular approach for separation in a cadaver. This was like a step-by-step approach. And it's a very nice illustration showing how you can get very good decompression through a tube, right? And this is a procedure that obviously, I'm not going to say it's easy, but it's a much less invasive option than in a traditional open surgery. We then published a technique, on a patient. This was published a couple of years ago, a minimal invasive tubular separation surgery, for cord compression. This is, kind of what the setup looks like. And yes, it's a big production, obviously not for every patient, but I will say, that the patients that we've done this, they recover very well from this, patients, much less pain, compared to a big open approach. We've had patients that leave the hospital, after a couple of days. They're able to resume their chemotherapy and get to radiation in a timely manner, which is what's most important in this patient. On the left, there's a picture, bilateral tubular approaches with percutaneous screws, this very minimally invasive. On the right, this is a picture of me and Dr. Yassari doing, 2 microscopes. And again, yeah, it's a big production, but I think patients can really benefit from this. This is our, our quick technique. And I'll show you real quick what it looks like. In terms of steps, it's pretty straightforward, right? The most important thing is, you're removing the inferior articulating process, right? Exposing the superior articulating process of the affected level, like right above the pedicles, you want to decompress, doing the posterior decompression, resection of the SAP, taking down the ligament, seeing, the border, right? The the lateral border of the thecal sac to give you, adequate access to the pedicle, and then going down the pedicle and doing the ventral decompression. Very small incisions. This is cranial on the right, caudal on the left, medial and lateral. We're exposing here, the bovie is going, exposing the lamina of the affected level, the spinous process above, inferior articulating process, the transverse process. We first remove the inferior articulating process of the level above to expose the superior of the affected level. You then do the posterior decompression, which is basically, doing a laminectomy. You resect part of the ligamentum flavum. You start seeing already the spinal cord right there. And then you go down the pedicle. Right? This is done, minimal invasive. And this lastly, I'll show you what very nice decompression you can actually get. This is just, finishing touches. Using, a downgoing curette to make sure that there's adequate posterior decompression. And then you go under the thecal sac as well, to make sure that there's good decompression. And then this was a case that we did actually bilateral. So you'll see that's the opposite side coming, under.
Rafael, this is a beautiful technique you're showing here. I'm curious if you've ever used a bayoneted ultrasound probe just to ensure that you've achieved adequate separation when you're doing this through a very small corridor like this.
Yes. Yes, not always, but yes, we have. Yeah, absolutely. I think that's extremely important. I think obviously the feel is part of it, but yes, using the ultrasound. I mean, we always use the ultrasound in our open cases, but particularly for this, I absolutely agree. I think it's extremely important, especially when you're doing, a more minimally invasive approach. The mini open approach that we spoke about earlier, right? When you leave the fascia intact, is also an option, right? You can do percutaneous fixation, through the fascia. Just doing percutaneous fixation, for a pathologic fracture is also an option. This is a case of a patient with COPD, malnutrition, anemia, low BMI, frailty index of 3. Just pathologic fracture, no cord compression. This is a case that we use a robot. And it helps, right? This is, a study from almost 10 years ago. There was a clinical series of 44 patients that were treated just with percutaneous screws, right? Preoperatively, 86% of patients had severe back pain. Postoperatively, this decreased to 0. In terms of complications, adjacent level fracture, in only 2%, one patient, or asymptomatic screw pullout, in one patient. So low risk and highly beneficial. Vertebroplasty and kyphoplasty, I mean, I won't go much into depth here, but, it's also an option for stabilization. We're trying to decrease pain and restore strength and height. This is just some illustration showing the technique. And it also works, right? This is a randomized controlled trial looking at balloon kyphoplasty versus non-surgical management. Outcome at 1 month, we see, here in red, patients treated with kyphoplasty had significant decrease in the pain scores at 30 days compared to controls. And then same thing for patients requiring analgesics, significant benefit in favor of kyphoplasty. The spine jack is a new, minimal invasive option. This is a device that's used to restore height, and it also, helps. And lastly, I'll finish up with describing, this endoscopic surgery is a hot topic in spine, and there are options for patients with tumors. Obviously, this is a very advanced technique. This is something that not everybody should do. And, even if you do endoscopic surgery, tumor endoscopic surgery is probably one of the last things you want to try. the main challenge is visualization and bleeding control. This is just a case, a posterior compression here on the left side, left pedicle. This was treated with an endoscopic posterior approach, and this is a CT scan showing the amount of bone resection. This study, looked at 29 patients, and they all had improvements in their functional status, in their pain scores, in their ODI or NDI, and their quality of life. There is obviously a learning curve, right? And this study particularly reported 4 complications. Some of them did require re-exploration and reoperation. So another option, obviously, an advanced option, but there are options for the frail patient. And then in general, can we treat frailty? This is some encouraging evidence in the geriatric population. Unfortunately, there's really not a lot of data in cancer or in metastatic tumor patients. Exercise helps, particularly group exercise programs, occupational therapy, nutritional supplementation, medication review. Sometimes patients, especially when they're very elderly, there's a lot of medications that may make them, a little slower. They may decrease their performance during the day. So all of these things have been shown to provide some benefit in frail geriatric patients. So take-home messages, frailty is a dynamic state that results in increased vulnerability. It's very common in patients with spinal metastasis. We saw, a prevalence from 50 all the way to 80%. There's no consensus on what the best tool is, but we need to choose one and measure it. Don't rely on a single tool, metric, or marker when trying to figure out what to do with patients, right? Look at the big picture, right? Look at the performance status, look at their hemoglobin, their albumin, their prognostic nutritional index, their frailty index. Look at the big picture. And also I know Dr. Baj is very advocate of this. Make the decision with the patient. Not every metastatic spine tumor patient is the same. Some patients, all they want is their pain under control. Some patients, all they want to do is even a chance at walking again. And some patients, all they want is something very small, right? I mean, so not everybody is the same. So we need to really make the decision with the patient. Many surgical options exist. And lastly, research. I think this is a very exciting topic. It's very dynamic. It's a lot of opportunity. There's a lot of things that we didn't, go into a lot of depth, but, things like sarcopenia, things like nutrition, frailty by itself, all of these are very, very interesting topics, for anybody in the audience that's interested. And as you mentioned, I'll be joining Montefiore Einstein in a few days, actually. We'll be having there's a research group there, particularly myself, I'll be looking at frailty and surgical outcomes, complication prediction, biomechanics, disparities, and others. If anybody, is interested in collaborating, shoot me an email. More than happy to work. And with that, I want to thank again everybody for being here, especially, Michael, Dr. Baj, Amna, Dr. Soli, and I'll take any questions.
Rafael, that was absolutely fantastic. I think that was probably the most comprehensive talk I've seen, to be genuinely honest with you on frailty and spinal tumors. This was absolutely a real tour de force talk. There are a couple of questions that are in the chat box. I want to make sure
absolutely
in the next minute or so. Triva T had asked, Dr. Ramos, would you have a decision tree of actions for patients with different frailty indices, pre-op planning, patient preparation, intra-op, and post-op rehab?
I don't have a decision tree of actions. I think that is, we would love to have a framework like the NOMS framework. But I think what we need to start with is that big picture, right? Is that putting, all of the information, right? What's the neurologic status of the patient, the oncologic, the mechanical, the systemic, and looking at everything, right? That's the most important thing. And I think, we've been trying to predict survival, complications, outcomes for decades. And I think probably a lot of us might have been obsessed with the Holy Grail, right? Trying to find that one tool that's going to predict everything, right? I don't think we're there yet. I think we need to look at multiple things, and that's how we make the decision, right? I mean, Dr. Yasari was also a big advocate for this. Is you need to look at everything, right? There's no one thing that's going to say yes or no. So this is why I think it's important to look at this in a very systematic way. But hopefully in years, several years from now, we're able to develop a framework. In terms about animal models, I'll be honest, I don't have a lot of experience with animal models of frailty. But at least, in geriatric patients, we saw in one of the slides that there are things that work. And I'm sure, in cancer patients, a lot of this support therapy, supportive groups, exercise, occupational therapy, having, somebody with you, like a partner or somebody that supports you throughout treatment, um, probably makes a big difference, especially if we're talking about patients that we're really just trying to palliate and may have limited survival, even though that's changing. But I think there is hope. I think there's hope for sure.
Rafael, I think we only have time for one more question.
Perfect.
Something I'd like to ask you, and I think we all kind of struggle with this, especially as you'll see early in your career, is before you really have that robust clinical experience, how you deal with these cases in urgent situations. How do you consolidate all of that information that you've poured a lot of time into
Yeah.
researching over the last decade or so? How do you consolidate all of that in a matter of minutes? If you have that 75-year-old patient or 65 that comes in with the
Yeah.
cervical thoracic junction pathologic fracture, they're losing function, they've been out for like 18 hours. How do you put this together at 2 a.m.? It's something I still struggle with till
Yeah.
this day. And the second part of that question is, how do you get that point across to your co-faculty, right? Because there's a good chance that you may be one of only two people who are doing complex
Yeah.
oncologic spine surgery, right? So how do you get that point across that you're going to be taking on this very challenging patient population during M&M and things like that?
Yeah. No, absolutely. I think that's a great question. I think the what you said, I think the most challenging is when they're losing function, right? Where they're still within that time frame. And I think that's a decision that, as you said, you might have to do by yourself at 2 in the morning, but that's a decision that you have to tell the patient, right? Now, there may be situations where it's extremely high risk, but I think for now, neurology probably supersedes everything, especially in that 2 in the morning case. Otherwise, if you have a patient that's been out for maybe, 48 hours, 72 hours, or somebody that shows up in the office, you may have more time to look at this comprehensively. But unless, the patient has really, really, extremely poor functional status, has been bedbound for days, BMI of 15, albumin of 2, something like that. I mean, it's difficult to say no to surgery when you see them losing function. And I think that's the most challenging scenario when they're still within that very, that time window.
Right. I think the most important point is to your point and um, just making that decision together, right? Just
Yes,
making
with
sure
the patient, absolutely.
everyone's on board with the decision. You're not pushing them towards surgery and just making sure that they're well informed of what they're getting into. So I think
Yeah.
that's all we have for time, Rafael. It's about 7:05 here.
Well,
So we
thank you.
really
Yeah, yeah.
appreciate it. Thank you for volunteering your time. This session will be recorded. It's going to be on YouTube. I'm sure it's going to get a ton of hits. I'm absolutely watching this again for reference
Thank you.
purposes. So this was fantastic, and we all wish you the best of luck at your new gig at Einstein. I'm sure you're gonna do
Thank you,
fantastic
my
there.
friend. Thank you so much. Thank you so much again. Thanks,
All right,
everyone.
guys. We'll see you all next week. Take care. Bye.
Yeah.